Making good time, evaluation of the learning curve with robotic sleeve, gastrectomy, some morbidly obese adolescents. Victoria Pepper from Ohio.
Yes. Thank you very much for allowing us to present our work. We have no disclosures. We aim to examine the learning curve associated with a robotic sleeve gastrectomy. In order to do this, we performed a retrospective analysis identifying 33 patients who are morbidly obese adolescents with BMIs greater than 40. Our variables included demographics, comorbidities, and the operative times with specific focus on the BMI on these operative times. Our analysis was performed by non-parametric regression analysis. As you can see, we had a predominance of both female and Caucasian patients. Our mean age was 17 and our mean BMI was 49. There was a significant incidence of obesity-related comorbidities in all of these patients, with the three most common being dyslipidemia, hyperinsulinemia, and hypertension. When we examined our mean operative time, it was 198 minutes, with the three factors contributing most to this being anesthesia preparation time, our consult time, and our closure time. However, when we examined these factors more closely, the two factors that had an associated learning curve were the total operative time and the consult time. Docking time provides an example of an operative time point that had no learning curve associated with it. One of the factors we were particularly interested in was how our incorporation of trainees would impact these learning curves. Here you can see the point where we incorporated our trainees and there was no impact. With our total operative times, we reached our first plateau at 13 patients. However, at this time, we incorporated our trainees and saw a second peak. Again, we reached a plateau after further experience. Our second factor, the consult time, showed a similar phenomenon, with an initial plateau reached at 13 patients. And again, the trainees caused an increase in these times. When we examined the impact of BMI on these operative times, we did not see any impact on either total operative time or consult time. However, on both anesthesia time and positioning time, increasing BMI caused increasing times. So in conclusion, experience with robotic techniques does lead to improvement in both consult time and total operative time, with a initial plateau reached at 13 cases. However, trainee participation will increase both of these factors, but none of these patients had any negative sequelae other than this increased operative time. BMI has no impact on either the consult time or the total operative time. However, there does seem to be an association with increasing BMI on both anesthesia time and positioning time. Thank you, and I'll take any questions.
Jeff Seitzman, New York. Thank you for that lovely presentation. I have a two-part question, primarily with regards to the robot. Number one is, were any of these patients conversions from other operations, such as a band? And part two is, did your placement of the ports limit your ability to do any additional surgeries, such as cholecystectomy?
So all these patients were new patients to bariatric surgery. And in regards to the port placement, none of them have impacted any further surgeries on these patients. Several of them have gone on to have cholecystectomies, but it has not impacted those future surgeries.
Is that something you could have done at the initial operation, or would it have required additional manipulations?
I think it would have necessitated moving the robot, because usually you position the robot over the left shoulder in this case, and for cholecystectomy, ideally you're over the right shoulder.
I have two questions for you, Victoria. I enjoyed your talk. One, have you looked at the anesthesia prep time for a laparoscopic group and compared it to this robotic group?
We have not in these patients, because we just don't have those time variables from our initial laparoscopic cohort that we presented last year. Going forward, we are planning a prospective study where we are going to evaluate all of this, as well as the impact on the surgeons and the anesthesiologists with both of these techniques.
And probably you will have then a real learning curve, because Actually, this is just about evaluation of the time used to introduce